Good evening, everyone. As I'll repeat what George was saying, hope everyone's okay during lockdown, and hope they've had no family members that have been affected by COVID. If they have, then I hope a speedy recovery. As George said, I've worked certainly with Scott for the last 10 years, and with George maybe for the past 6 years. But I just wanted to tell you a little bit about myself before we get started. Not so much my credentials, but I graduated in 2010 from Glasgow Caledonian University, and at that stage I was not really sure as to whether podiatry had everything that I wanted to offer as part of a solution-based profession, really. We were going down the road, certainly in my degree, of lots of chiropody-based stuff, lots of nail surgeries, those types of things. But biomechanics started to show its head in my last year of my degree. Unfortunately, I got offered a job around about the same time to go and work with Scott at one of the clinics. And fortunately, then for the past 10 years, that was solely biomechanics, and I've been very fortunate to be able to just do that. I can continue to do some soft tissue property bits and bobs, but the majority of my stuff is all biomechanics, and it's the best decision I've ever made. Since that, I then about 3 years ago, I found out that I was having a daughter, so I decided that rather than looking after the clinic that I was working in, I decided to go part-time. But the beauty of still being able to do biomechanics and utilising my Footscan plate and everything else in between meant that I only have to work a couple of days a week and still be around to look after my daughter and see her grow up. So I feel very, very privileged to be able to do that. And podiatry's given me that footing, pardon the pun, to be able to do that. I work currently as part of 6 clinics across East Anglia. As you'll find out throughout this talk, I've got a much better appreciation of what's going on at the pelvis, and certainly then in terms of how the feet then interact with the pelvis. I believe a lot of the things, I speculate by saying 80% of the issues that I tend to see typically start at the pelvis, and the feet are somewhat then adapting for the position. I wouldn't quote me on that, but it means that if we can begin to get a fuller understanding of what the lower limb's doing, then we can work as part of an interdisciplinary team, as well as working on your own and getting really good results. The clinics that I do work in, though, only one is podiatry solely led, 2 are physiotherapy led, and then the other 3 are osteopathy led. So it gives me a really well-rounded approach in how podiatry can work as part of these teams. So a little bit about me there. But what I was wanting to just talk to everyone about is about how I use it. Now, each of the clinics that I work in are all very, very different. I use a 1/2 meter Footscan plate. I use them in corridors. I use them in long rooms. I don't put any vinyl over the top of them. I don't use any foam walkways, anything along those lines. My thinking behind that was that I don't necessarily want patients to be overly conscious of where the plate is, but I don't want them to be guarding or really trying to throw themselves onto the plate. So typically, as part of my assessment, I would get patients to walk up and down the corridor, walking on the plate, walking off the plate, in the region of about 10 times, just purely to make sure that they don't know when I'm recording. I tend to record after those 10 steps and then ask them to continue to walk. But the whole idea is to try and get them to avoid trying to plant their foot down, but equally as well, wanting them to try and have at least a normal, comfortable gait. And therefore, then it gives me actually I'm much happier with the results that I tend to get. I tend to do, if I've got a 1/2 meter plate, I tend to do 6 steps one way, so 6 left feet and 6 right feet. I tend to do that purely to see how the foot posture adapts and changes. So if there is any issues with them trying to plant their foot or place their foot in a particular way, I will try to avoid. I can remove those scans as a result of that. How I tend to use the foot scan just generally, patients are typically triaged, and a lot of the physios and the osteopaths, they get me involved pretty early on in regards to getting a very quick foot scan plate from a static view, but also from a dynamic view, just to see where we are from the very first day that they walk through the door. It doesn't take very long. It takes all of a couple of minutes, and patients are usually pretty well receptive to just getting an idea of what their feet are up to and what's going on. But really explaining to the patient that we're all about measuring outcomes, and therefore then being able to have a basis of measuring those outcomes. The foot scan allows me to do that brilliantly. So I then go on usually then to, as part of then using the foot scan, then within doing my dynamic or my gait analysis that I would usually do. I typically do that in barefoot. Then I tend to do it in their shoes that they've worn today, any orthotics that they've potentially off-the-shelf insoles that they've used previously, and then laterally, if I've then made an intervention, then look at walking them back over the plate with the foot scans, with the orthotic or intervention that I've put in, again, just to check to make sure that what I've done is helping, it's not hindering, and I can then report back to the other clinicians that are involved to demonstrate to them, as well as demonstrating to the patient, that we've made a positive intervention. In terms of how I tend to then look at measuring outcomes on the foot scanning system, but also as well, what I'm looking for when the foot comes onto the plate, I'm looking typically at 4 things. So you can see them on the PowerPoint right now. So the tools that I typically use to assess foot scan success are the symmetry of the movement, and the direction of the movement, the quality of movement, and the speed of the movement. I don't typically believe that there is a perfect foot scan for the foot to run on, and equally I don't typically believe that there is a perfect posture that everybody that should be working towards it. I feel like the world that we live in, everything has to be adaptable, and therefore then if there's we have to have adaptable posture, and we have to have adaptable feet as well. So if by utilizing these tools, it gives us an idea whether what we're doing, or whether we're maintaining the foot in a supportive way, which isn't going to lead to any further issues. So in terms of determining the symmetry, I check, and let me just change this over. I tend to look at the zone classification really quickly as part of the triage, which you can see in the bottom left here, through there, and that very quickly gives you at the bottom here a foot type. So you've got a heavy high arch foot, and you've got a light high arch foot. So you've got, as far as the foot scan is concerned, 2 very different feet. Now, people at the around listening to this, I don't know if that's going to be a surprise or not a surprise to you, but I typically am seeing a huge amount of asymmetrical foot postures and in different foot types when we're seeing them on the foot scan classification system. And certainly as a standard, I would want to be looking to get them the same. Now, whether it means that they're both heavy high arch feet, or whether they're both light high arch feet or flat feet or whatever else in between, I want them doing the same thing. That's number one priority. What I'm then looking at is just generalized plantar pressures that are running over the sole of the foot. So we can see straight away, don't want to insult anybody's intelligence, I'm sure George has gone over what you can see on the foot scan plate, being the areas of red being the areas of highest pressure, and working on a color spectrum down through yellows, greens, blues to whites, where there's no contact with the plate. I want those pressures to again be even, and I want them to be the same. Again, in terms of I would avoid looking at whether that's right or wrong straight away. It's just making sure that the foot posture is symmetrical and even, or mirrored, rather than necessarily completely symmetrical. And if we can see that, then it goes quite a way along the lines of showing that the foot posture is rather relaxed, and is therefore then we're not seeing a drastic guarded or compensated way of moving. And that's my aim. In terms of the direction To determine the direction of movement, I tend to then look at the center of pressure line, which is the dotted line that runs through the center of the foot. If I remove the foot axis line or the midline of the foot, that's the dotted line is the line I typically look at when it comes to direction. I'm looking for both of them to be pointing in the same direction, and if there are any changes in direction, so to speak, I want to be noting them, and again making sure that they're the same. Again, if one's doing one thing and one's doing another, that is an area of concern that I would want to try and change, and I would want to try and get them to, I would want to try and get them to this S-shaped movement, which I'm sure George and Scott have already highlighted to you guys, and that I want the initial heel contact to be around where my hand is right now on my screen, and then for it to then move medially before then moving laterally around lateral to the midline of the foot before then changing direction just underneath the third metatarsal back towards the first and second toe. Now, as I said, the degree of the curve at the bottom, as long as it's doing that movement, I know that the calcaneum is then working alongside the talus, and I know that there's then a level of rotation that will then allow the rest of the leg to rotate further up. But in the meantime, I know that the foot's then resupinating and then stabilizing itself through its midfoot before then preparing itself to take off. By doing that, I'll be very happy then with the direction of movement, again, if these are the same. I'm also then looking at the degree of abduction or adduction. So in terms of documenting the degree of abduction. Now, again, this is more of an eyeballing element to this, but if we've got one foot that's very typically neutral or adducted and the other one's very, very clearly abducted, again, there are areas that we want to try and rectify, or at least begin to bring them in, so they're certainly in a more of a mirrored position. In terms of the quality of the movement, I then look again back at the center of pressure again. So if I was to remove here, I'm looking, you can see that as the center of pressure moves on the right hand side, that there is a smooth movement from the heel contact through. Now again, with Jim, who's a friend of mine, he doesn't mind me showing his feet. He hasn't got the perfect initial lateral to medial heel movement and gut back round, but that movement is still, I'm still happy with that it's a smoother movement. There isn't any juttery, there isn't any sharp medial lateral movements, which would suggest an unstable movement or an accelerated movement. You can also see that the dots between the lines that tend to accelerate through the midfoot. Again, I want these to be the same. So again, we can see with Jim that it's actually more progressive. It's smoother running through the midfoot compared to the left-hand side, where we do have a bunched element just prior or just before forefoot contact. In the same way, the heel contact and the initial movement is a very sharp medial movement. So in Jim's case, I would be expecting to see there to be, certainly when looking at the patient walking, a very sharp rear foot eversion, because their movement appears to be uncontrolled. It's very, very quick. And then as you can then see, the center of pressure then continues to fall on the medial side of the foot axis, and it's unable to necessarily resupinate or unable to catch itself again as it's trying to, to resupinate, to stabilize the foot. And the last one I tend to look at then is also, and I've already touched on it there with the speed of movement with the dots running through. I'm also looking at the speed just generally. So looking at how long in the stance phase of gait, the left and right feet are in ground contact. Now, in terms of giving you facts and figures, I'm usually looking at around about 50 milliseconds is the maximum amount of difference between each side. I want to make sure that these numbers are again more even than uneven. For example, if we're finding that we are seeing that there are excessive differences in stance placement, then that again is leading to make me question whether there is active pain, whether there is a chronic condition, or whether we're actually finding that the patient may simply have a leg length discrepancy. So it just begins to begins to encourage me to ask questions, and certainly encourages me to then look at how, if I've missed something in my physical examination, for example. So based on that level of thinking, if we then take my feet, for example, so bear with me here. For the stance there. So if you then look at my feet and we look at exactly the same concepts I was looking with Jim, if I go straight to the zones, we've actually got, apparently I've got 2 normal feet, so better than Jim on that front there. So that's a tick. I'm already happy with that. Then looking at, oops, if I go back to there again, then we're then looking at the symmetry of movement. So the plantar pressures again look pretty even. So from left to right here, so centralized loading through the second metatarsal running through to the 5th metatarsal, and even amounts of calcaneal pressure as well. So again, all of the lesser toes are in ground contact, and there is then higher levels of pressure on my second toe on both sides. Again, I'm happy with all of that because of it's because of how mirrored it is, because of how even it is. In terms of the direction of movement, again, the same with Jim previously. I'm as much as we do have this rear foot eversion and the S-shaped movement going from lateral to medial then up onto the lateral border before then taking off. I'm really not particularly happy with my heel contact on both sides. I'm happier with my right side than I am with the left, but you can see if I remove the center of pressure line, those changes in direction show a real heightened instability. And unfortunately, I have fractured and dislocated my left ankle historically, and with poor rehabilitation, I'm still seeing this now, even 20 years down the line, that my foot control as I'm planting is not as I would like it to be. Also as well then, taking that on and moving the center of pressure line running through into its propulsive phase and looking at this takeoff here, we already told you that my left ankle is arguably compromised and certainly weaker. And then when it then comes to looking to take off and propulsion, my propulsion isn't in a straight linear line. Again, the right hand side isn't too sharp either, but specifically the left side really twisting away. It's highlighting that there appears to be some form of functional locking at my first metatarsal. Now, there are other ways in which you can ascertain that. Sometimes there is a gap. There isn't a gap between the first and second metatarsals, so there's a complete opaque color. That can highlight that there's a compromised first MTPJ, but in this case, the abductory twist or the twist off on the left-hand side, with me personally, is absolutely relevant, and that abductory twist is coming because I'm unable to support my foot. I then tend to overload the first ray, and then I have to then twist away as I look to take off. So I'm then having a lot of changes through my second toe as I'm twisting and abducting off of that IPJ, and it's now starting to migrate. So something that I'm obviously clearly a hypocrite telling my patients to do things and I'm not doing them myself. When it comes to the quality of the movement, again, I've already touched on the rear foot positions here, but these are all sharp movements. There's nothing smooth about it. So, we want these all to be rounded. I need to make sure that, again, if there are more rounded edges, then we're more likely to have been able to absorb shock and then continue to translate forward. If they're really sharp, opaque sharp angles, then they're typically you're typically going to see high trauma as a result of that, and those high trauma movements are more likely to cause patients discomfort. Equally as well, these high pressure areas could also then lead to this an unbalanced posture, or are they again looking to try and compensate or offload one joint for the other? So all things at your physical exam will tend to highlight and pick up, but using the Footscan plate to then take it on a step further, but then also then implementing your treatment and see how has it changed with the foot posture, how has my orthotic therapy changed as well. The speed of movement as well, we're talking about what I was talking about earlier is looking at my left and my right feet from here. Now, we're out of my 50 millisecond threshold, my barrier really. So if we were to click play and let that run through, what you will see is you'll see my heel on my left hand side come up very early. Now, that's strange considering that there is a higher level of time with my foot on the ground on the left-hand side. But this is because of the weakness within my forefoot. I'm prolonging loading going through my forefoot. And as a result of that, all the pressure, all the loading is then going to be locking my first ray into my first medial cuneiform. Subsequently, then I'm not going to be able to dorsiflex my hallux effectively, hence the reason then that we're twisting. So with an early heel lift like that as well, I know that it's because of my ankle, but equally as well, patients could be presenting with a difference in leg length, both structural and functional, and equally as well as a result of, say, repeated torsion or twisting of an ankle. You will see these types of presentations with an early heel lift that subsequently we want to try and manage and get on top of, because it will then lead to other changes throughout the forefoot that again we would want to try and avoid, especially if it's going to then lead to hallux deformities or lesser toe issues, those types of things that typically become more acute for patients, in my experience, and they tend to become the problem rather than the problem that is really causing it all. What we can then do is looking at, so say for example I've taken my foot scan of barefoot, and then 3 months later then I want to see them again and want to walk them over barefoot, I can still use these parameters as my checklist to determine, as I said, whether we've actually made those improvements. And if I can highlight them to the patient at the start of the gait analysis or the start of the treatment, so to speak, then we can then know that, yes, I'm going to be improving your center pressure, and I'm going to be lowering the plantar pressures here, here, and here. I'm going to be making sure that your foot posture is symmetrical. These are all things that you become accountable for, fair enough, but you will be able to make those changes and then come back and check and prove that you've made a success of your treatment. I hope that all makes sense to everybody. Let me swing back to here. So utilizing your physical examination and utilizing this framework or these tools give us a much better grounding or much better understanding of how your foot works, how your patient's foot works, and how the foot scan can then how the foot scan can then assess it and take a look at why these movements occur. As I said beforehand, with the physical examination, or with how, again, I would utilize it within a foot scan scenario, is that sometimes I ask people to walk over the plate first, look at what the foot scan's saying, and then come back and look at certain aspects or elements through the rear foot or through the midfoot or through the forefoot, whether there is instability at the ankle, at the knee, at the hip, or if there's leg length discrepancies, etc. But typically, it's a case of doing my patient questionnaire first, then looking at doing a weight bearing, a non-weight bearing, then a weight bearing examination, and then looking at the foot scan. Because I'm 9 times out of 10, I'm pretty convinced that I know what I'm expecting to see before I get them onto the foot scan system. And so therefore then by doing so, it then gives me an opportunity to then confirm my thinking, but there is still plenty of times that it throws up a cat amongst the pigeons, and I then have to then look back and think about my physical examination to then determine whether I've missed something. And usually the foot scan is absolutely right and I've missed something. So it just gives me, when you've got using it, so you use it continuously, it keeps you in check as well. So with that, obviously, as I've said on the presentation here, so we're continuing to use the framework or the tools, as I was describing beforehand, to give you that foot classification. Then you then combine it with the mobility in your foot and your physical examination, your joint ranges, your muscular tension, and that then gives you a massive amount of information that you can then begin to understand how that foot's working. And looking at the center of pressure lines individually, as well as looking at them together, again, helps me personally, because typically when I'm looking at intervening, my approach is always asymmetrical. So if we were going to be doing, if I was going to be making an intervention with orthotics, whether I was doing it with exercise rehab, typically I'm doing one thing for the left foot and I'll usually do the opposite thing for the right. And then again, look 6 weeks down the line, well, how has that changed things? Has it actually brought those asymmetries that I've seen? Has it brought them together? Has it brought them further away? Has it begun to minimize patient symptoms? Again, looking then at your heel strike, as we've touched on beforehand, into your mid stance and into your propulsion, provides, and then looking at each of those individual tools, so the symmetry, the direction, the quality, the speed in each of those different stance phases of gait, again, just open up a huge door of understanding, and well, I'm hoping that it would really impress your patients, because you've got a full understanding of how you can help them. The other things that I typically, let me bring it back to the Footscan area there. Right, yeah, so other things that I tend to look at in terms of assessing progress, but also in terms of really looking or seeing how I'm bridging my physical examination then through into the Footscan analysis from here as well. And I look a lot at the first metatarsal or certainly the first metatarsal head as a real driver for foot posture. I firmly believe that if we don't utilize it, or if we don't look after it, it can then tend to lead to torsions, as we've already touched on with the abductory twist, but also as well, it then tends to affect how your midfoot and how your rear foot then tend to work. So as much as we can look at it from the heel strike then affecting into propulsion, I still believe that the propulsion or the first ray can then affect how the rear foot then tends to work. I don't know how everybody feels about short metatarsals, but I believe in them quite considerably at this moment in time, well, certainly at this moment in time. And when it comes to looking at when metatarsals come into contact, now, in this case, my first metatarsal isn't short. However, if it's loading a lot earlier than my right hand side, and then it's then locking the movement and maintaining and keeping it lateral, then I know that I need to again unlock this metatarsal, because as we've already highlighted, the prolonged loading through the joint then tends to lead to locking at the first metatarsal, and that metatarsal then again abductory twists away. The other typical things that I'm tending to look at are whether the lesser toes are whether they're even, whether they're bilateral as well. So again, typically you're seeing that lots of toes that tend to be retracted or not even there at all, with patients or with people that are in pain, or people that again they're in acute injury compared to chronic injuries as well. So the toes are a real big indicator as to whether you're one, it's an indicator for the types of symptomology, the types of pain that you're going to be experiencing, but also as well whether that patient is compensating and guarding for their symptoms at the appointment today. And then looking back at those 5 or 6 scans that you've taken previously on that right foot or on that left foot, you can see whether that happens on every single time, or whether that's just one out of the 6, so to speak. The understanding then is that, well, with all of this, we can then think about the classifications, going back to what we said within the zones about whether you've got a high arch foot or a flat foot, or you've got a light high arch foot, those types of things. You then combine that with your mobility, and then you're halfway there in regards to being able to, in terms of the aims of what you want to try and achieve. If you've got a rigid foot, you're looking to try and unlock it. If you've got a mobile foot or a hypermobile foot, you're looking to try and make it a wee bit stiffer. It just, again, enhances, gives you that knowledge, and gives you that gives you knowledge, gives you that toe in the door, so to speak, in regards to getting patients, giving them the right care. What I also then look at doing is thinking about whether you can begin to predict injuries, and looking as to whether I can well, guess as to whether some patients have had certain issues, or whether some people have had injuries or operations or anything along those lines, based on how their foot posture is working. And in the past, people have sent in scans, so to speak, that we've looked at, and by looking at certain movements, or looking at, based on this framework here, so if the foot is supinating excessively compared to the right, or if there is an uncontrolled rear foot movement on the left hand side, like we've already seen with myself, then that does then lead you to believe, or think about what type of injuries, or what type of traumatic injuries, say, a supinated foot would have, and what type of torsional injuries that a pronated foot would typically have. So I'm expecting to see, if there's a supinated foot, that there's potentially been an Achilles tendinopathy, or there's been calf fat pad trauma, or there's been metatarsalgia, looking at clawed toes, retracted toes, specifically a gastroc, a gastrocnemius pull or calf strain, patellofemoral joint pain, sacroiliac joint pain, but on the opposite side, I would expect from a supinated foot, it just following a pattern of movement and following that restriction of movement. In my experience, that typically leads to those types of issues. And in the same breath, though, on the opposite side of things, if you're looking at a foot that's pronated or continually wants to pronate, then I'd be suggesting more of an Achilles tendonitis, or more of an inflammation within the tissues because of the torsion. Plantar fasciopathy, obviously, your first ray issues, such as a bunion, HAV, or whether you've got a tib post tendon injury or a tib post tendon dysfunction, then medial knee pain, iliotibial band issues, trochanteric bursitis issues, but then the SIJ point, sacroiliac joint pain on the same side. If the foot is pronated, in my mind, then the tibia will rotate. There'll be then internal knee rotation, internal patellar rotation, internal femur rotation, and anterior rotation through that side. And if that's happening, I know that there's a couple of osteopaths on the course which will tell me that it's not always the case, and that hence the reason that I will always then refer to osteopaths if I'm seeing this type of pattern, and they can tell me either I'm right or I'm wrong. But the hope is then that they can then deliver the right course of treatment. They then get arguably the patient then into a neutral position, and then you utilize a podiatrist, or in some cases osteopaths will then implement their own orthotic therapy, so that they can then hold the pelvis in that position. You then utilize say Pilates instructors or yoga instructors or personal trainers to then load that up again, and then cement patients into a really safe position that, again, they become adaptable, they become strong, and then it begins to help their foot posture and their posture globally because of that natural adaptation. I think people sometimes just get quite surprised that you can typically at least highlight or ascertain where one area of pain has actually occurred, or whether they've had, whether they've had an operation or something along those lines. I think they're quite shocked, but maybe that's just me. By knowing these, or by knowing this pattern of movement, and certainly then by predicting these injuries, or predicting the history of these injuries, so to speak, we can then again tailor our approach to make sure that we can offload these structures. We can then look at stabilizing, we get the right people involved, and again, just giving the patient the best care, really. What I just wanted to touch on, just more from a conclusion perspective, was I hope that the tools that I've talked about, or I've highlighted, so to speak, just give everybody an understanding of how they can start to look at, say, their own feet or patients' feet, that you can then begin to build in and develop more and more understanding about what the foot is doing. Once you know what the foot's doing, then you can then create or implement the changes as much as you can implement your changes, albeit whether that is orthotic therapy, whether that is strength and conditioning, or whether that is manipulation or taping or acupuncture or anything else in between that you would want to create an adjunct therapy or create a change in the way that the limb's loading, then it works very well, and then you reduce the risk of their injury. But I then look at comparing, retesting, checking, and just always going back over those 4 or 5 points, and then looking at whether there is something that I've missed, and if so, then I can go and assess it from there. I hope that has all made sense. I hope it's not been so muddled. This has been my first webinar, so I'll let George come back in again, and if anybody's got any questions.
Yeah, so if anyone's got any questions at all, whether that's specific to things that Paul's just gone through, or perhaps you maybe have unanswered questions from actually using Footscan again, whether it's just been over the last few months or anything at all that you feel would be beneficial to have an answer to from a software usability point of view and what you'd expect to see from that foot. So if anyone does have any questions, if you want to just type them into the chat window and I will fire them at Paul. First question come through. Paul, do you use the risk analysis? And that's from PhysioFit in Jersey.
Personally, I don't use it. For mainly just for the reason that I tend to look at the foot classification first. I know that it's there. We've looked at it, and I've looked at it in the past, so to speak, and I've got a very high risk there. But no, I don't tend to. I'm much more comfortable looking at the foot scan. But typically, when the system was first introduced to me, it didn't have any of the risk analysis screens or images. So I suppose I'm a little bit more old school on that front and looking just solely at the foot images and then looking at the zones screens that I've highlighted before.
Okay, I've got a question from Trevor. When would you feel that an adult may not require their prescribed device any longer? Could their symptoms return after they have stopped using them?
Personally, no. I think I would be looking at trying to wean that individual off. So not necessarily going cold turkey, but asking them to still maintain or still be in their device. Say, if we're talking about 5 days a week, I'd still want them to be, and they're in a very active job. I'd still want them to be in their insole, say Monday, Wednesday, Friday, and then start to wean it off gradually. And you can look at, or they can explain into the patient then if they do start to begin to experience any return of issues or return of then we can always put the orthotics back in again. But if we do it gently, then the patient should feel like they're confident in it, and they, in my opinion, I wouldn't expect their symptoms to return.
Okay. Next one coming through from Carl Bell. Paul, please can you repeat the injuries you are likely to potentially see with supination?
Yeah, so typically what I would expect to see, so working from the foot, so if the foot is supinated, I'm typically expecting that to be a rigid loader. So if we're talking about gait and the way that the foot's moving, then straight away heel contact, and specifically that your heel spur type issues, which would manifest in the plantar aspect of the heel, would be number one. I would then look at your gastroc, specifically gastroc rather than soleus, but looking at the insertion into your Achilles off of that, but more from a direct pulling element without torsion, because I'm expecting the subtalar joint and a supinated foot to be inverted, and therefore then there's going to be minimal tibial torsion as a result of that. So therefore then there shouldn't be any Achilles torsion, well, not any, but there should be minimal Achilles torsion. So I'd expect it to be coming from the pull of the gastroc. I would then expect there to be patellofemoral joint issues from the hyperextension that's present. And I would also then expect to see SI joint issues, but on the opposite side. So I would expect then that on the supinated side, I would expect the SI joint to be open, but I would expect the right hand side to have adapted. Now, if both feet are supinated, then that's a complete. I'll leave that to. I know Trevor's an osteopath. I'll leave that to Trevor, but I would be expecting the opposite side to then be adapting as a result of it. But I think that was all the ones I mentioned. I also mentioned metatarsalgia and these types of trauma, capsulitis over the ball of the foot. Just naturally, as the lesser toes are more likely to retract, there's higher levels then of high levels of pressure over the second to fourth metatarsals.
Next one, I know there's very mixed opinions on this, but a question from David Eade. What's the youngest you personally would recommend orthotics?
From my experience, if we're looking at paediatric intervention, I would be sending them to paediatric physios for further assessment of strengthening work. So, because I'm really expecting, I really like children not to be in orthotics, and we can deal with them when they get a wee bit older. But the hope would be if they can control themselves at this age, they're less likely to require intervention when they're older.
Sure. Just to add on there as well, something we tend to recommend is if you are going to prescribe orthotics for children, not to go too mad from a modification point of view. It's really important to just get a stable heel more than anything, just to support that medial arch. Okay, I've got a question from Janie. She tends to get people running over the plate and using it for running shoe assessments. Also keen to introduce into cycling shoe insoles. How would she use the plate for this? So I don't know if you, Paul, personally have used Footscan in the cycling world.
No, I haven't entirely, but through the conversations that we've had, George and Scott, the best approach should be looking at the static screens and looking at the balance screens and looking at doing single leg squats on top, or trying to replicate the position the foot's going to be in. If we're in that say a half squatted, single legged squatted position, we should then be able to determine where these plantar pressures are. And typically, from my experience of cycling and dabbling in cycling, I just want the foot to be as rigid as possible, making sure that it's going to be stiff and stable for the upper limb to then walk over the top of it. But I would then typically get patients into a single leg squatted position on the balance software.
Yeah, no, that's correct. I've just had a message come through saying Dave's Provide Cycling Runs has had brilliant success with those. I think one of the nice things about the cycling insoles is they are very rigid, so the natural shape of them has a very high medial arch support, but also, of course, the full forefoot is 3D printed as well, which can be post-medial or lateral. So actually, in the cycling world, it's not just seen as an injury prevention measure. It actually has elements for potential performance enhancement and efficiency through the pedals as well. Next one coming through from Nikki. Do you or your colleagues see any instant changes post-treatment, such as any manual therapy or needling, for instance, in certain patient groups, such as plantar fasciitis pain, for instance?
Yes. Not so much with needling per se, but with laser therapy, K lasers and some shockwave therapies. I've seen, and certainly taping, I've seen patients will go and limping and then walking out, so to speak. So there's, I have seen that personally. And soft tissue work, soft tissue mobility, I do regular foot and ankle mobilizations, and they can yield very good results, not necessarily in your acute inflammatory conditions or chronic inflammatory conditions such as plantar fasciopathy, but in other conditions, joint restrictions and traumatic joint inflammation, we can improve that certainly through the first MTPJ, and by mobilizing it, I've had people get on really, really well with that, and asking them to continue to do that at home has helped massively for them.
Okay, just a couple of people have added to my comment on the cycling insole, saying that they've actually used the ski orthotics for cycling in the past and had good success because they are slightly narrower. So that's potentially another thing to bear in mind. We've got a message from Prim down in London. If a client has quite severe bunions, would you design an orthotic with first metatarsal support, or try and promote movement in the first metatarsal joint?
Good question. I suppose it depends on the severity of the bunion. That's a bit of a cop-out answer. So personally, I think I would actually try to lift it. I would try to support the first metatarsal rather than cut away and let it drop. In the past, that's the approach I would have taken, but I'm finding more and more that by doing so, I don't tend to have as much control over the forefoot, certainly everting and potentially increasing load through the first MTPJ. So I've now changed tact and decided to go more for half Morton's and tact style adaptation. So I think you can get that on. I'm sure you can get that on the Fits. So that works really, really well for that. Just being able to lift it up. So therefore, then we still have the forefoot control to minimise any further changes to the joint, but at the same time as well, patients should be able to get relief at the same time.
Okay. I haven't received any more questions for the time being, so unless that's the case, I'm going to say thank you everyone for joining us this evening. I hope you've found some value in that, even if it's only a couple of things. Obviously, it's a continuous learning process, as of everything.
As we've got everybody on, also maybe if everybody's on screen, is if they've got any ideas, we can't promise to carry them all, but if you've got ideas of future webinars or future subheadings that you might want to look at, then please put it through to me, George, info, and then that gives us some ideas and content to start putting new ones together that will be beneficial to the group.
Cool. Okay. Right. Well, we'll call it there for today. And yeah, thanks very much for your time, Paul. Soon I'll be in touch with the next one. Many thanks.
Yeah, thanks.